I mentioned, and there are some interesting similarities between tinnitus, severe tinnitus, and chronic neuropathic pain. And I would like to discuss some of these here, and we can learn from what the pain researchers have found in their studies of chronic neuropathic pain and apply that to tinnitus. And there are also some new revelations in tinnitus research that is useful for people who are interested in pain and interested in specifically chronic neuropathic pain. So it is interesting to compare these two diseases and make maximum use of understandings of either one for the other one of these two. The goal is, of course, to find better treatment for tinnitus. We must admit that presently the treatments available for tinnitus is coming, but it is not in any way complete. There are many forms of tinnitus. We have very little help to offer. So the similarities between tinnitus and chronic neuropathic pain is there are no visible signs of illness and no objective tests. At this time, when people to a great extent rely on tests for diagnostic purposes, then this is of course a big disadvantage. And the other thing is that tinnitus and pain are not life-threatening, so they don't get the attention that you would give to life-threatening diseases. In general, you can say that tinnitus and pain does not receive much sympathy from relatives, or friends, or healthcare professionals, in fact, also. But it does definitely affect the quality of life. These two diseases, tinnitus and pain, chronic neuropathic pain, destroy the life and reduce the quality of life considerable, cause suffering to many people. They also have strong emotional components, these two diseases, so you'll have often depression and other mood diseases, affective diseases together with tinnitus and pain. A French surgeon has said that the only tolerable pain is someone else's pain, and this is true also for tinnitus. Everybody else can tolerate tinnitus indefinitely, of course. What is the likelihood of having tinnitus? Vestibular schwannomas almost always have tinnitus. That, of course, doesn't mean that people with tinnitus always have vestibular schwannoma. And that is a very important thing, because you have patients coming to you and say, I have tinnitus, do I have a brain tumor? And the likelihood is, of course, little for that. Meniere's disease is, per definition, tinnitus, a triad of symptoms. One of those are tinnitus, and also trauma to the auditory nerve. And trauma includes surgical trauma, of course. So high likelihood, old age, most old people, or many old people will have tinnitus, a varying degree, hearing loss, but not all people with hearing loss have tinnitus, and not all people with tinnitus have hearing loss. Traumatic brain injury, of course, have often tinnitus, but they have so many other things, so people don't pay much attention to the tinnitus. Blast injuries, exposure to impulsive noise, shock noise, and then there are some specific diseases that have tinnitus, Wilson's disease and Down syndrome also. So tinnitus has many different forms and different severities. So it is unfortunate that we call all these diseases for tinnitus, although they are so different, so they really should have had different names. So it can be just annoying or distracting or made difficult to do intellectual tasks. But if you have tinnitus that is just annoying and distracting is the most common form, and a person with very severe tinnitus talk with another person who say, well, I also have tinnitus, no big deal, what's the problem? And that is because we have the same name for these. Severe tinnitus affect an entire person and cause severe suffering. So severe tinnitus may be similar to phantom limb syndrome, where people have feelings of tingling or pain in a limb that doesn't exist. So the abnormality must be in the brain in that case, and the same is the case with tinnitus. You cannot think of an amputated leg give you pain from that leg. It must occur in the brain. So the anatomical location of pathology is the brain. It is phantom sensation, or ghost sensations. So the severe tinnitus is similar in that way, that it is a ghost sensation. There is no physical sound that produces this sensation of sound, which is tinnitus. And there is people who have a severed hearing nerve who have tinnitus, even though they don't have any connection to the ear. So that is one of these evidences that the brain itself can cause tinnitus. So we have also in neuroscience revised the way we look at the brain. There are many new things coming during the last few years that has made the common view on how the brain is organized very much changed, upside down, I would say, more or less. So, for example, many tasks involve many parts of the brain, and several parts of the brain are involved in most tasks, and some parts of the brain can do more than one task, and many parts of the brain interact extensively with each other, and the mind can control many brain functions. Even motor functions can be controlled by the mind. For example, in our area of hearing, we have had a relatively simple explanation for the interpretation of speech sounds and generation of speech sound. This is Wernicke's area communicating to Broca's area. This has been the prevailing hypothesis about both speech production and speech understanding. Now we know that understanding spoken words involve a large area of the cortex, a large area of the brain, not just Wernicke's area as we saw before. So that modern view also affects diseases. Often we thought that a specific disease that it could be traced back to the brain had just one location in the brain that was pathological. Now we know that many parts are involved. For example, tinnitus, it has not just one part. It is not just the auditory part of the brain that is involved in tinnitus, but many other parts are involved, such as attention network, distress networks, memory networks are all involved, all pathological in severe tinnitus. So that is just another reminder that tinnitus tinnitus is a very complex disease, and the same is the case for neuropathic pain. They are actually plasticity disorders, which means that the pathology is caused by plastic changes. And we now know that it is many times a matter of the connections that are abnormal. Maladaptive plasticity is what we would call plasticity that is not beneficial, and that can cause altered connections between different brain structures, and it can also cause different relations between inhibition and excitation in a certain group of nerve cells. And the dorsal medial thalamus is involved bypassing the primary cortex, which of course makes it different from ordinary perception of sound. Earlier we were very happy to know that cells in a structure connected to cells in another structure, that's structure A connected to structure B. Now we are a little more sophisticated. We of course want to know which cells connect to each other, but we also want to know how strong is this connection. And the strengths of connections are very important. And we can now begin to trace back diseases to different strengths in connections. Maybe the same connections as in normal, but the strength is different. Here's a pattern where we show connections between different structures of the brain, and they are marked by colors that indicate the strengths of the connections. For example, for tinnitus, we know that there are changes in connections, and we have known for many years that patients who have tinnitus for a long time, their tinnitus seems to be different in a way, and we now can trace that back to different connections. Here is tinnitus of short duration. It is mainly connections from the one side, from the temporal lobe. Long durations has many more connections and very much disorganized, I would say, connections in these long duration tinnitus. So we can show neuroscience abnormalities that are different in people who have had tinnitus only for a short period compared to tinnitus for a long period. So there again a reminder that tinnitus is different, and different tinnitus of course need different treatment. So how do we find which treatment is good for a particular person, and how do we diagnose this and find which treatment is the best treatment? And what treatments do we have for tinnitus, by the way? We have several same kinds of treatments as we have for central neuropathic pain. We have medications, we have neuromodulation, we have behavioral therapy, and treatment of the underlying diseases. Many diseases are accompanied by tinnitus, and tinnitus is just one symptom of an underlying disease. Treating the underlying diseases is, of course, a very effective way of treating tinnitus. So, I have shown several forms of evidence that tinnitus is a far more complex disease than earlier assumed. And in many situations, particularly in severe tinnitus, the ear is actually not involved very much or at all. So it is a brain disease in many forms of tinnitus, like central neuropathic pain. So how are we attacking that? A multidisciplinary approach will be necessary for success in treatment. We need better methods for diagnosis. we also need to understand where tinnitus comes from directly in detail, and it doesn't help to treat the ear if the problem is in the brain, of course. That is, here is one thing that we are plagued with in the United States. I don't know how you are here, but we have all kinds of people who want to sell their wear, and they also want to sell how to treat diseases in a very simplified way. And here is one advertising that show how to treat tinnitus, and that is probably not the way to go. So we also should have different goals for treatment of tinnitus. If you have a patient who come and have tinnitus and say, doctor, can you help me? If you say that, yes, I will eliminate your tinnitus. If you reduce the tinnitus to a value where the patient doesn't have lots of problems, they say maybe 90%, but there's still tinnitus, then the patient will probably maybe go to another physician and say, no, this physician did not do as he or she said she would, namely eliminate my tinnitus. So it's much better to say that you will reduce the tinnitus, you will manage the tinnitus to a level where it is less burdensome, and also give the patient hope for success in treatment. Saying that there is no treatment and you will have to live with it for the rest of your life is actually an invitation to suicide. I have seen that personally, actually. So that is important. So it's also important to realize that tinnitus and chronic neuropathic pain have two parts. The one for tinnitus is the sound the patient hears. That's usually what you focus on and the patient focus on. But the other one, namely the effect of the tinnitus on the person causing suffering, is not what people usually look at. You have exactly the same for pain, chronic neuropathic pain. It hurts, it's felt that it's painful, but there is the other component, namely the suffering component, and that is different. And the strength of the tinnitus is not directly related to the degree of suffering. You have the same with pain, with chronic pain. So what should the aim of treatment of tinnitus be? Reduce the perception of tinnitus or reduce the suffering that a person feels from tinnitus? The loudness of the tinnitus is often what is measured as an indication of success of tinnitus treatment, and that is not always similar to the suffering. So a decrease in the loudness of tinnitus does not necessarily mean that the suffering has decreased. So you can also have it the other way, that which I also have seen personally, actually, that patients have the same tinnitus. You ask the question, is the tinnitus changed? And the patient say no. And then when you further ask the question how the patient's life is, we'll find out the patient can now sleep, the patient can now work, and so on. But the tinnitus is the same. So that is, again, interesting that you should then focus, of course, on the suffering component of tinnitus. There is another thing that often accompanies tinnitus, and that is hyperacusis, lowered tolerance to sounds. And that is, of course, a very unpleasant thing. Treatment of underlying disorders is very effective in many ways of treating tinnitus. Temporomandibular joint disorder is often accompanied by tinnitus, and treating the TMJ problem will, of course, reduce the tinnitus or eliminate the tinnitus, but also neck problems is often causing tinnitus. Sinus problems can cause tinnitus. Sinus problems may not be what the patient come and ask for. The patient come and ask for treating the tinnitus, and you will have to ask the patient what they have also. Maybe they have sinus problems or neck problems. Ear problems, often seen, for example, in operations for otosclerosis, they often have, patients often have tinnitus. After the operation, the tinnitus disappears, and that is because silence causes tinnitus. Silence is the strongest promoter of neuroplasticity, and as I mentioned, neuroplasticity is involved in many forms of tinnitus. So lack of sound is a problem. There is now also use of cochlear implants to treat tinnitus, because that establishes an input to the brain. Neuromodulation is a way of treating tinnitus for pain. Transderm. How do I go back? Okay. The transderm. For pain, tense transderm electric nerve stimulation has been used for many years, and that is effective in treating many forms of pain. And you also have stimulation of the brain structures. Deep brain stimulation is important for treatment of pain, and can also be used for treatment of tinnitus. That is just beginning to come now, but it is not used. Here we go. So electrical stimulation of the dorsal column for pain, premotor cortex, stimulation of premotor cortex and supplementary motor cortex can give relief of pain, and stimulation of thalamus. For tinnitus, sound stimulation, as I mentioned, hearing aid, masking devices can be helpful. Electrical stimulation of the ear, not the auditory cortex, dorsal thalamus maybe, is common for treating of tinnitus. Transcranial magnetic stimulation is a way of treating tinnitus. Medications are, of course, also used, of course, for treating pain. Medications are very effective. The non-steroidal anti-inflammatory drugs such as ibuprofen is, of course, very effective. Opioids are effective, and some antidepressants can enhance the effect of opioids in pain stimulation. For tinnitus, the first really studies showed that drugs could manipulate or decrease tinnitus was lidocaine. Local anesthetics, that is a sodium channel blocker, but it cannot be administered through oral administration. It has to be intravenous and administered, and that is not practical. But alprazolam, Xanax, has been shown to be effective in some individuals with tinnitus, and clonazepam. Clonazepam is also effective in some studies shown, and may be antidepressant. But unfortunately, many of the SSRI antidepressant types, they actually have tinnitus as a side effect. Sound treatment and counseling was developed by Pavel Jastrobov, and this is now used worldwide for treatment of some forms of tinnitus. Stimulation of the somatosensory system can relieve tinnitus. Electrical stimulation of the ear or the skin behind the ears can relieve some form of tinnitus. It's not because it stimulates the ear, but because it stimulates the somatosensory system. Nerves from the skin around the ear make connections to the cochlear nucleus, because the auditory brain system wants to know which direction the ear is pointing. Think about a rabbit that can move its ear, and that's exactly what we have. We can't move our ear very much, at least, but the nervous system is the same, and that is why that kind of electrical stimulation can reduce tinnitus. Electrical stimulation of the left vagus nerve is effective also for tinnitus in some instances. That is experimental still, but that kind of stimulation has been used for many years for stopping epileptic seizures. A couple of years ago, when I checked that, there were 50,000 people in the United States who had this electrical stimulation of the vagus nerve for treatment of intractable seizures. Depression, it is also approved for reducing depression. Pain is also studies that show electrical stimulation of the vagus nerve can be effective, and obesity, eating disorders of various kinds, and also addiction is now being studied as for treatment of the vagus nerve. Acupuncture is a form of neuromodulation, of course, is effective in many cases of tinnitus. Hypnosis, a form of central control of tinnitus, is also effective, but it is very labor intensive, of course. Reversal of neuroplasticity as a treatment of plasticity disorders. Electrical stimulation again of the vagus nerve promote plastic changes. It is the same as stimulating the nucleus of Maynard, and it is effective also in reversing plastic changes. So electrical stimulation of the vagus nerve paired with sound stimulation is now being tried for treatment of tinnitus. So a person's reaction to his or her tinnitus is important for the outcome of treatment. It's essentially two ways of approach tinnitus. It is catastrophizing or non-catastrophizing. Catastrophizing is not a good way of doing it. The person who is catastrophizing will say fear of sound and avoid noisy environments and isolation and so on. Catastrophizing, patient will say, my tinnitus is bad today and it will probably be worse tomorrow. And I will probably have tinnitus all my life and there's nothing that can help. That is the catastrophizing approach. Non-catastrophizing, my tinnitus is bad today, but it will be better tomorrow. Confrontation, I will do something for my tinnitus, I will seek treatment and so on. That is the better way of doing things. Coping is also a way of handling tinnitus. It is a learned skill. I have tinnitus, but tinnitus does not have me. And that is a positive way of approaching a disease like tinnitus, and for that matter also chronic neuropathic pain. So there are two different kinds of coping: active and inactive coping. So evaluation of treatment. I mentioned that in the beginning, that if you just evaluate the sound, which is often done using an analog scale, you only get half of the tinnitus. The suffering should also be evaluated in the same way in order to evaluate effectiveness of tinnitus treatment. So where may progress in treatment come? Well, predicting the future is, as somebody has said, not very easy. This is actually sticking out your neck to try to predict the future, but I'm sure that anyhow that I will do that and say that we can think that some improvement will come by a multidisciplinary approach, learning from other disorders such as pain, and the way we evaluate treatment, suffering. At least in the United States, physicians have stopped asking the patient how they feel. They will instead look at the MRI or some other tests. But if you go that simple way and ask the patient how they feel, you will actually get good results in knowing what's going on. And you also should set reasonable goal for treatment, management, and not cure. So I am involved in an organization called Tinnitus Research Initiative, and we have a flow chart that I don't know how many would follow, but you can see it's very complex. And I just show that to tell you that tinnitus is a complex disease, and it should be treated and approached that way, that it has many different forms, and there are of course also many different kinds of treatment that may be helpful. Thank you very much.
Anyone would like to have any questions?
My name is Professor Kalimullah Taheem. I'm from Karachi, Pakistan. I must admire and appreciate the way you conducted this presentation, and a lot of things that we have not known and we have come to know through you. It's been very nice. The fact of the matter is that tinnitus doesn't have a major problem as pain, but the problem is the ringing in the ear, and that is a problem that we have not been able to sort out. I don't know, we have tried so many drugs. We have tried antidepressant, we have tried vasodilators, we have tried vitamins, vitamin B1, and we have tried so many things, but I don't know. This chapter of tinnitus has always been a sore in the eyes of the ENT people, and not been able to cure that. The only thing that we have to say that you have to live with it, with this sort of disease. Major problem in our country that I've seen is basically ringing in the ear and not the pain.
This is unfortunately many people's experience, that they try a lot of things and it doesn't help, and the patient get disappointed and the physician get disappointed, and that is unfortunately the situation today, that there are only a few kinds of tinnitus where treatment really is effective. But these kind of tinnitus are very rewarding, really, and unfortunately, the only thing I can say is that we will have to wait, but there is a tremendous research efforts going on, and in my own area of neuroscience, there are more and more people who are basic scientists who are now working on tinnitus. I think that was so for many years. There were really not many people who did scientific studies who worked in tinnitus, trying to find out what is it really that causes tinnitus, and that is probably what we need. So unfortunately, I have to say that be patient. It will come. It will come.